Here we go. Good morning. This meeting is called to order. Welcome to our June board meeting. Our meetings are going to continue to be hybrid. The Healthcare Authority staff will be on site, and board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide has information about how attendees can turn on our closed captioning subtitles. We're going to do roll call. Myra.
Here.
Carrie.
Good morning.
Allison.
Good morning.
Well, there's 3 cups of coffee right there.
I was trying to use the mic right, but red does not feel like go.
Red is go.
Red is go.
Yep, you're good.
3 cups of coffee.
Okay.
People, how is it not green?
Amy.
Good morning.
Pamela.
I got the red thing. Good morning.
Donna.
Good morning.
And Terry. Is Terry with us virtually? There you are.
I am. Good morning.
Good morning, Terry. And Katie Hatfield from the AGO.
Hello.
And I'm Lou McDermott, the deputy here at HCA and the chair. With board members attending both in person and virtually, it will be helpful for the board to hold their questions until each presentation is done or when the presenter pauses and asks if there are questions. Board members attending virtually will also watch in case your Zoom hand goes up and indicate you have a question. We're going to have one resolution scheduled for action today at today's meeting, and the public will have an opportunity to provide comments regarding the resolution during normal procedure before the board votes on the resolution. The public is also going to be able to provide general comments at the end of the meeting during the public comment period, which will be after or before exec session? Before exec session. Okay, then we'll come back from exec session and adjourn. All right. As a reminder, if the public has questions during a staff presentation, the presenter's contact information is included at the end of the presentation, and you're welcome to email them during the meeting to capture questions for the response after the meeting. Dave's going to provide us an overview of today's agenda. Sir.
Good morning, members of the board, Chair McDermott. I just want to comment that the last time we had this many board members in a room was March of 2020. So it just seems strange that much has passed. If you think about all the things that have gone on in all of our lives and our work and personal lives, and it's just so exciting to have so many of you here in person for a board meeting. So just wanted to acknowledge that. Today, we'll start off the core of our meeting. We'll be bringing you for action the resolution that was introduced at the last board meeting related to the Uniform Medical Plan Hearing Instruments benefit and the benefit level that kind of aligns with your new authority to set the benefit based on a bill that passed the legislature this session. Then we have another resolution that we've identified that we want to bring to you for introduction today and teeing up for action at the next meeting related to the high deductible health plan that comes with a health savings account. The IRS keeps doing its thing and having to adjust some of the requirements for those to be qualified plans. So we have a new approach that hopefully we don't have to have you vote every year on this for the rest of time. And then we're going to bring some information about the First Fill program, a conversation and a benefit that many of you are aware of because of a variety of public comment this season, as well as constituent correspondence that you've been receiving in your packets. We wanted to provide some additional context about the way that benefit changes are communicated after the board takes action at the end of the board season as we go into open enrollment, just to give you insight of the standard processes we use and then use First Fill as a specific example of those processes and improvements that we're always looking at to help members understand what is changing in their benefits. Then we thought we would do, Shauna will be doing a presentation about the federal public health emergency unwind. The federal public health emergency concluded in mid-May. This is our first meeting since then, but we thought we would talk about some of the impacts on the agency, just generally healthcare, insurance and coverage in our state, things that are happening on the Medicaid side of the house, things that are happening within our own program. And then we also do have a resolution that's embedded within that presentation about some future COVID test coverage that we'll tee up, again, not for action today, but hopefully for action at the next board meeting. And then we will be moving after public comment into executive session, our first really diving into executive session about the rate development process that's currently undergoing as we move forward into the rest of the board season on bringing the premiums out for public view and for your action by the end of the season. So that's what we're here for today.
Dave, I was reading, did you mention the restrooms? And
I did not. I just looked at that. And
Okay.
we have so many people, you might not remember. The restrooms, you go out this door down here at the, I'm pointing at the right, you walk down the hallway, you'll see elevators, you look to the left, and there are the bathrooms. And if we have an emergency, we're all going to the really full parking lot across the street. It's extra full today because we have a lot of new staff starting the first day of the month here. So outside that window over there, if there's some sort of emergency, that's where we all go.
Awesome, thank you. Any questions? Excellent. All right, our first up is we're going to be voting on a set of meeting minutes from last month's SEB board. The meeting minutes are behind tab number 3. Are there any comments from the board? Seeing none, do I have a motion to approve the minutes as written?
Motion to approve the minutes as written.
Thank you. Is there a second?
Second.
Thank you. All in favor, say aye.
Aye.
Any opposed? Hearing none, January retreat minutes are approved as written. Next agenda item is going to be the May meeting follow-up. And Dave is going to provide a reminder for us related to the topic brought up at the last board meeting.
I don't, good morning again, everyone. I don't have materials for you to look at, so no flipping of pages right now. At the last board meeting, I actually wasn't here at the last board meeting. It was the first time that I had not been present for a sub-board meeting, and I appreciate Jean Bowie stepping in and helping lead that meeting with the role that I typically provide for you. But at the meeting, Jean provided some insights about Benefits 24/7, the online system that we are launching here at the Healthcare Authority that is a single platform for both the PEB and SEB programs. So SEB My Account, which was the program that was IT program enrollment system that was launched with the launch of SEB in 2020 will be retired, and then that functionality will be subsumed and enhanced within Benefits 24/7. Jean at the time was giving you an update on the fact that we were scheduling the date for the launch, moving that from May into June. We are on target for June 12th. So we're a little over a week and a half away from there. I want to let you know that some of the reasons that we had delayed or transitioned that date to June have panned out well. We've had very successful overall additional data migration testing, which was extraordinarily important, just so, especially in the PEB program, where they are, the analogy we've been using is that SEB is moving from, the 2022 model to the 2023 model of a car, and PEB is moving from horse and buggy to a car. So we were really wanting to make sure that we had data migration really solid, especially for the PEB program, so that there wasn't a lot of extra manual keying, which I know school districts would have been very challenged to have helped support us if that had been what the system was for launching the SEB program. So we've had much continued success in those data migration testing. And then additionally, we had a lot of outreach that we continue to need to do with both PEB and SEB employers to make sure that all of the individuals who were properly identified to have access privileges into the system. When we were last with you, or when Jean was presenting, we had about only 25 to 30% of those access privileges identified for both PEB and SEB employers in each program, and now we're in the low 90 percentiles. So we've had a lot of improvement in that area, and gives us a lot more confidence that there would not be people who were not aware that the system was changing, wouldn't be able to access it on day one, and are receiving more training and getting more questions answered. So those are all things that are helping us feel more confident about the success of the transition on June 12th. So I just wanted to let you know that that is still on target, and the next time we meet, we will hopefully be telling you about the success of that transition. So that's really the update that I wanted to provide you for that important system change that we have here.
Thanks, Dave. Any questions for Dave? All right, good luck with that. IT project's super fun. Yeah.
Super fun.
Super fun. Next agenda item, UMP Hearing Instrument Benefit. Janice McAlpin, Senior Account Manager in the Employee and Retirees Benefits Division, is joining us to present a vote on the UMP Hearing Aid or Hearing Instrument Benefit Resolution. After Janice reviews the resolution with us, we're going to ask for a motion to adopt. A second, we're going to invite public comment and amendments. I will ask for discussion from the board until we're ready for a vote. Our materials behind tab number 4.
Good morning, Chair McDermott and members of the board. For the record, my name is Janice McAlpin, and today I will be presenting on UMP hearing instruments. Moving on to the next slide, I'll cover some follow-ups from our May meeting. So I took back and confirmed the following information for the over-the-counter hearing instrument coverage for the health savings accounts, flexible spending arrangements, and limited purpose FSA. So you'll see there on the screen of what's covered and not covered for OTC hearing instruments. And for the limited purpose FSA, why it can't be covered is because that FSA is only for dental and vision. There was also a question on cochlear implants under House Bill 1222. And since that's not mandated by House Bill 1222, the data for cochlear implants was not included in the fiscal analysis. So those are the two specific follow-ups from our last meeting.
Real quick, Dan, I just want to put a finer point. When Janice says that the limited purpose FSA is limited to dental and vision, that's not an HCA decision. We can thank Congress and or the IRS. So just wanted that to be clear.
All right, so if no questions, we'll move on to the next slide and go a little bit into some more follow-up that we did after our last meeting. So on this slide, we went back and did a review of some neighboring states and coverage for hearing instruments. And what we saw was a lot of variability. You can see the overview here of Oregon, Idaho, and California. So at a high level, what we found is that those states typically have a lower benefit amount, and many times that is subject to deductible or coinsurance, often with a limited network. And our Washington benefit for the proposed resolution 2023-05 for UMP is for children, adults, and it's not subject to the deductible and coinsurance like some of these other states have. We also have a broad network access. So on here, you'll see that Oregon broken out by school employees and public employees, Idaho for the state and higher education employees and any opted-in school districts, and California's for their employees.
One other piece, we've worked on this. This was actually a question at the PEB board meeting specifically, but we like to share the information with both boards, and that's one of the benefits of being able to cross-pollinate the questions that all of you have as board members in either setting. As we look generally outside of public sector employment, but just commercial insurance in general, I wanted to let you know that it's actually quite unusual for there to be a mandate for adult hearing aid coverage like there is in the bill that passed Washington. There's a small handful of states. Generally, the legislation in various states has focused on children. And as Janice and I learned, children can be defined in a variety of ways: 12, 18, 21, 24, 26, hike. There's all of these potential ages that exist out there, but the vast majority of legislation across the country is focused mainly on children. There's a few states that have adult coverage, and Washington is now among those small states. So just wanted to share that it's that trend in the commercial insurance market as well.
Thanks, Dave. All right, moving on to the next slide, I'll give a brief overview again on HB 1222 that I covered in last month's meeting. So as of today, it has been passed and signed as of May 4th. And so it becomes effective January 1st, and that impacts the general large group commercial market, and that includes employees and dependents of all PEB and SEB program plans. So that'll expire the current law the end of this year. It'll be effective January 1st, and that requires coverage for hearing instruments at no less than $3,000 per year with hearing loss every 36 months. So that's just a quick update on that House Bill 1222. And moving on to the next slide, I'll bring up the last slide for May meeting on the examples of implementation. Most of this information you've already seen, the first 3 bullet points, but I did add a 4th bullet point speaking specifically to some of the stakeholder feedback that we received. So we don't historically recodify or repeat all requirements from applicable statutes and board policy resolutions or even in program WAC. So we do this to minimize the chance for inadvertent conflicts between a board decision and the statute that's enacted by the legislature. So the resolution that you'll see on the next slide and that you saw last month, that's really focused on the board's discretionary decision-making authority related to that specific benefit limit amount under the new law, the $3,000 benefit limit. So I added in that 4th bullet so you could just see some of that language from the legislation and why it's not included in the resolution. So if no questions on the examples, I'll move into the next slide, which is the resolution. for action today. I'll cover a little bit of the stakeholder feedback real quick before I turn it over to Chair McDermott. But as a recap and what you see in your board materials, many stakeholders provided a lot of positive comments. One stakeholder proposed to be clear without coinsurance, but we feel like the language without cost share in that first section already covers that. So we decided not to include that in the middle piece and the last piece of the resolution. And we received comment from the OIC regarding section 1, subsection 2 of the legislation, and that's what I just covered on the previous slide, but we didn't feel like it was necessary to call that out in this resolution because they're already purchased or intend to obtain the initial assessment, fitting, and adjustments. We didn't feel like that was necessary to include it because it's mandated in the legislation and it's already clear in the statute. So bringing this forward for Chair McDermott to turn it over to the board.
Do we have questions before we start?
Chair McDermott, I have one additional comment I want to provide. We received a stakeholder question, I think it was earlier this week, feels short weeks are confusing, about if we could more publicly share the stakeholder feedback that Janice just summarized. And so I wanted you to know about something that we're looking into doing. You have received, for the past couple of years, receive a copy of the raw emails that everyone sends, and then what I call an adjudication log, which has a copy of the substance of those emails and then how the agency responded. I'm realizing that going forward that adjudication log might be very helpful for the public to see as well, so that they're not just receiving only the summary that Janice gave. So we're looking at going forward, including that adjudication log that you've already been receiving as an appendix to these types of presentations. And so I just wanted you, and more importantly, the public, in case there were questions about that, we just never thought about including that, and nobody had asked until this week. So we're going to look at changing that process just to increase the transparency of the feedback process and stakeholder review process. So I'm sure that you all had I haven't had, since we started doing that process with the board, I haven't had significant questions or concerns about how HCA has summarized feedback, and I think that could be important for public transparency too. So just wanted to share that that's a direction that we're going to be heading in the future for you and the public.
Question?
I have a question. This is basically around UMP. Doesn't cover Kaiser and doesn't cover Primera. Is it just generally anticipated that they will just follow suit with whatever UMP goes with?
Generally, yes, is the answer to that. And as we move into further the rate development process, we'll have presentations about the various changes, and we'll make sure that there is specifics about how they are implementing the legislation. And we like to bring UMP to you first. You have a lot more discretion related to the direct management of the self-insured plan, and we try to tee that up so that the carriers also see what the board's decisions are to hopefully align. Sometimes that alignment isn't instantaneous, sometimes it's the next year. So we'll see exactly, but this legislation has an effective date of January 2024. So we do anticipate that if the board does pass the resolution at 3,000, that most of the other carriers are anticipating doing the same thing.
Thank you.
Other questions? All right. We're going to take a vote on Resolution SEBB 2023-05 UMP hearing instruments. Resolved that beginning January 1st, 2024, prescribed hearing instruments in all uniform medical plans will be covered up to $3,000 per year with hearing loss at least every 36 months without member cost share. Coverage for members enrolled in UMP Achieve 1, UMP Achieve 2, and UMP Plus are not subject to the member meeting the plan deductible. Coverage for members enrolled in UMP High deductibles are still subject to the member meeting the plan deductible. Is there a motion to adopt?
Pam Cruz, so moved.
Is there a second?
Mrs. Allison, second.
Are there any comments from the audience? Who is monitoring our... Fred? Mr. Yancey?
Yes, good morning.
Good morning, you have the floor.
Well, great. Just moving into my house. I wrote a letter to the board on this issue, and the members I represent are concerned about this because indeed it's a cut in benefits. If you look at the usage of hearing aids and the cost, you had at least submitted at a previous meeting you have 438 people that chose hearing instruments that were cost $4,000 or more versus 95 people that chose hearing aids that were $3,000 or less. And so my concern is that this is indeed a benefit cut. I understand why, and I understand the expectation of what will happen as a result of it, but my members are very concerned about it because it, and what I have not seen, and I'm not schooled in the art of audiology, is, what is the difference between a $3,000 hearing aid and a $5,000 hearing aid? And I certainly understand there's one, at least one was purchased for $9,000, and that seems kind of, must have been made out of titanium or something, but that issue aside, there's an issue in hearing aids in terms of quality of hearing. Does $3,000 just get you basic hearing, where you can't hear highs and lows, you just hear kind of the mid-range? Or, what about tones and adjustments, are they automatic or manual or whatever? I just don't know enough, and there's not been information shared as to the differences in terms of the characteristics between the $3,000, $4,000, $5,000. But again, 438 people would have been adversely impacted by this because they chose hearing aids higher, and of course 95 people, would fall under that. So just have concerns. So whatever the board decides, we'll live with it. But I appreciate the time to speak. Thank you.
Take your time,
My name is
Fred.
Fred Yancey, and speaking on behalf of school retirees. Thank you.
Thank you, Fred. Do we have others? Do we have any comments from the board?
I just had a comment, or I guess maybe it's a thought, so just help me process my thought, because I'm only on my first cup of coffee.
Okay, we'll work with you.
So it says, in the motion or the resolution, covered up to 3,000, and I went back to page 4, under 1222, it said no less than 3,000. So I'm just wondering if that's why we went with up to, correct?
Myra, so the question, just in case it wasn't fully captured, was the difference between the resolution saying up to 3,000 and the legislation saying no less than 3,000. No less than 3,000 is why we're bringing a resolution to the board, because there's discretion. You just can't be below 3,000. And we wanted to be clear. There was at least a conversation that up to 3,000 means that if there is a reimbursement for 2,100, you're not entitled to the other $900 that's you're fulfilling the full 100% reimbursement for any amount that is below 3,000, but you could get reimbursed up to 3,000. So hopefully that provides a little bit of context for that. And Myra said thank you.
Other questions or comments from the board? All right, this is going to be a roll call vote, starting with Carrie.
Yes.
Myra.
Yes.
Amy.
Yes.
Allison.
Yes.
Donna.
Yes.
Pamela.
Yes.
Terry.
Yes.
And Lou McDermott, yes. Resolution SEB 2023-05 passes. Thank you. And Janice, you're up again. SEB UMPI deductible plan IRS minimum deductible. Janice is still with us to talk over the proposed resolution regarding SEB UMP high deductible plans minimum deductible. No action is scheduled for resolution today. Materials behind tab number 5, assuming we would bring it to the next board meeting for a vote. Yep.
Real quick, Lou, Chair McDermott, if I could cover the last couple slides on my hearing instruments.
Sorry.
That's okay. Just
You
real
passed
quick.
me the baton.
You're supposed to pass it back.
Oh. Now we found out the mistake, yes.
So just real quick on hearing instruments still, some of our next steps, I know some of the concerns of, this benefit changing, how do we communicate that to members, stakeholders, all that. So we have a pretty exhaustive process for UMP. We have tons of documents, tons of locations for information where it's posted. So we're going to work on now updating our HCA member communications, making sure those are all ready for open enrollment, and as well as making updates to the Regents member communications and on their website. So and out to providers as well. So they're realizing the change that is going to take effect January 1st. There are some internal system updates that we'll need to make too for Regents, members calling into customer service, making sure that they're getting the right information from the customer service representatives. So a lot of updates will be happening in the next few months to get ready for open enrollment and January 1st. So moving on to the next slide, that's the end of my presentation if there's any questions. Okay. So you have me for the next one as well, which is also UMP, and that's for the high deductible plan, IRS minimum deductible. So good morning, Chair McDermott, members of the board. For the record, my name is Janice McAlpin, and I'll be presenting on this for you today. Going on to the next slide, I'm going to cover some history and timing of IRS changes. So historically, the IRS issues guidance for these changes for the high deductible health plan in each spring and summer. So there's not a definitive date on when they usually issue guidance. So it's typically in the spring and summer. And here is a chart of back to about the last 12 years or so of what has changed and what the minimum deductible in that middle column for the self-only and the minimum deductible on the far right-hand column for the family. So you can see every couple of years it has seemed to rise and rise. And for our PEB plan, that's the UMP's HSA qualified plan back to its inception in 2014, we have not increased it except for last year in 2023. So it was always meeting that minimum deductible. It increased from $1,400 to $1,500 in 2023. For SEB, same story, but the first SEB plan for high deductible was in 2020. So we also had to increase in 2023 to $1,500 and $3,000. So the IRS just issued the 2024 guidance, and that self-only minimum deductible increased to $1,600 and $3,200 for the family, and that's that top row in 2024. So we have to make a change with that guidance. And why we're wanting to bring this to the board is because we don't want to necessarily wait for what the IRS says every year. June is sort of late in terms of getting everything ready for open enrollment. And so we wanted to bring forward a proactive resolution, minimum necessary to maintain that qualified high deductible status. HCA wants to be prepared, and we don't want to rush the board or have to call a special session. So moving on to the next slide, that brings forward the proposed resolution for your review today, no call to action. But the proposed resolution for SEB 2023-06 is that for plan years beginning on or after January 1st, 2024, HCA shall set the annual deductible for UMP high deductible health plan at the minimum annual deductible level established by the Internal Revenue Service, the IRS, to qualify the plan as a high deductible health plan without further action from this board. I'll pause for any questions.
I do want to assure the board and the public that during the June-July processes is whenever we get the guidance, at the next subsequent meeting, we'll share what is changing and we'll make sure that that is information that's publicly shared. But that way we don't have this potential gap or timing problem. We're unfortunately at a point we had hoped last year when it raised that, like, if you look at the prior chart, there's usually it doesn't change every year, but we all know we're in kind of this inflationary period and we don't want to just be chasing the floor forevermore. And so this felt like a reasonable possible approach.
Janice, has it always matched? Has our number always matched the IRS number?
No, back to that table, ours was set at 1,400 since inception. And so I don't know if we can go.
Can we go back?
Back a couple slides, please. Thank you. So from inception of our PEB CDHP plan, which is the same as the SEB high deductible plan, it was set at the inception of $1,400, and we didn't have to adjust it until last year.
I see.
because the IRS came out with the $1,500 amount, so we had to raise it last year.
I see. So we were higher than the IRS in
Mhm.
previous years, but then it caught up and now we're just staying with it as
Yeah.
it goes up. So a change in methodology and then we don't have to adjust the number every year. Understood.
And like Dave said, well, it'll come back to the board of, we're changing this, but you wouldn't be required to vote on it every single year or every other year.
How's the board feel about that? Everybody feeling good about that?
Smart.
Okay, awesome.
Okay, perfect. So we'll move back to slide 4 for next steps, please. Okay. So for next steps, same as with any proposed resolution, we'll send that out for review by close of business tomorrow. We'll incorporate any of that board feedback into the proposed resolution. The stakeholders are asked to submit their feedback by no later than June 12th, and you'll see that email address on screen. It's really long, but that's where the email will come out of, and ask stakeholders to respond to by June 12th, and we will bring that to the board for action at the June 22nd board meeting. So moving on to the next slide, that's the end of my presentation. If there are any questions.
The baton is coming to me.
You may take the baton.
Thank you. Thank you today, appreciate it. All right, our next agenda item, Christine Davis, Senior Account Manager in the Employees and Retirees Benefits Division, is going to join us today to go over some insights regarding the 2023 implementation of Kaiser Permanente of Washington's First Fill program. Her materials are behind tab number 6.
Hi, good morning, Chair McDermott and members of the board. My name is Christine Davis.
I
And
gotta
as
stop looking up at the screen. I'm like, people.
Hi, everyone. So, as mentioned, I'm presenting on the 2023 Kaiser Permanente of Washington First Fill Insights. And this presentation does include KPWA options, the PPO product. So, next slide. And then the first slide here, board votes. The SEB board voted to approve KPWA and KPWA options 2023 plan designs in July of 2022. Next slide, please. This slide overviews the standard communication methods. After the board votes, HCA transitions to prepare communications for open enrollment through existing methods, such as newsletters, OE materials, both print and web, plan-specific materials, and benefit administrators receive forwardable emails from HCA that include links to OE communication, materials to send to members. And the newsletter link excerpts are available in the appendix. Next slide, please. So how was First Fill communicated in open enrollment materials? Fall 2022 OE aligned for plan year 2023, HCA's OE webpage, Intercom newsletter, the October edition, webinars through virtual benefits fairs presented by KPWA and hosted by the HCA, included First Fill program flyer and maintenance medication list. SEB program KPWA microsites included First Fill program flyer, mail order, pharmacy information, maintenance medication, drug list. The OE webpage post, link, excerpt to newsletter, virtual benefits fair webinar reference links, and microsites are included in the appendix. And this is a continuation of that. November 2022, KPWA sent retention letter with First Fill program messaging to existing KPWA members. First Fill program flyer. First Fill language included in the 2023 KPWA plan comparisons, 2023 KPWA summary of coverage and benefits, 2023 KPWA evidence of coverage, and letter and flyer are available in the appendix. So this slide, First Fill HCA lessons learned. HCA is assessing how to improve visibility of plan design changes to members who may not be considering a plan change during open enrollment.
And, this is really like the challenge. If people, we have a system in which elections are evergreen. If you are happy and you just want to keep doing what you're doing, you don't generally have to engage. You have to engage if you want to elect FSA or DCAP because that requires an affirmative election each year. And you also need to engage in our system if you have a potentially your spousal surcharge situation, and we generate targeted letters in those instances. But if you're generally happy, you might not be paying attention. I know I'm guilty of that. the last couple of months of the year, well, really all time is just really fast. And you just get distracted and you're like, I'm happy with things. So this is really the tough part to crack is how do you make sure that people who really might want to know this information and aren't actively looking for it, see it. And see it in the plethora of information that is inundating us, not just from the healthcare authority, but from all aspects of our lives. That is really the tough piece to crack that we're trying to see what can we do about that for people who don't engage, because the system isn't set up if they're happy to engage. So that's really one of the challenges. But we did want to make sure that the board had copies to be able to see the way that things are communicated. But we can't, I sometimes I don't even read my own mail. Like I can't make somebody read something, but we wanted to share how it's being communicated in our standard formats. And we know that everyone isn't necessarily reading it, and it doesn't answer every question. I know that there's a lot in this particular instance of concerns about how provider networks, who's in network, how Kaiser is able or not able to answer questions about specific entities being in network. And that isn't really digestible into 2 bullet points on something, a postcard, but being able to get people enough to pique their interest and engage to get those questions answered while we work with our carriers to make sure that they are able to answer accurately questions, like for example about networks. So I just want to this isn't unique to First Fill. This is the system in which we have our benefit system today, and it's a big challenge.
Carrie, don't want to put you on the spot, but up in King, did you guys run into the same issue, or did you they had to select every year? How did you crack this nut, or same problem?
Same problem. It was an evergreen system because if you don't do that, people forget to sign up for benefits.
Right, and then you have other problems. Yeah, okay, so same issue. Yeah, tough one.
Okay, so moving to the second bullet, during the plan renewal process, requiring written carrier insights on impacts unique to rural members on proposed plan design changes.
Also in this one, I want to highlight the key part of the sentence is written. We have these conversations as we're going through the renewal process, and I don't want you, board members, or the public to think that these types of conversations haven't been happening for years, but we were like, oh, let's have that proactive in their initial responses to document some of their initial thoughts to have that kind of more formal documentation. And we wrote rural because of the context of First Fill in which that's come up, but it's not just rural. There are other aspects of kind of the demographics of the populations that we serve that we ask these questions about. So I just want to share, it's not limited to rural, and the main emphasis here is to start having some more written, proactive initial documentation to jumpstart those conversations that we have with the carriers during the negotiation process.
Okay, and this is the last slide of the presentation. Oh no, I lied. Sorry, just kidding.
No lying.
I knew it was brief.
No
I wasn't
lying.
trying to rush it. So speaking of the carrier, so Kaiser Permanente Washington did provide a statement to include in the presentation. I will not read it, but it is available for those that want to. And the statement from KPWA is outlining its ongoing focus related to high quality and accessible care that is also affordable.
And as we move to the true last slide of questions, I do want to remind the board and the public, we are anticipating, during the rate process, we've received information about what the rates could look like with and without the First Fill program, and we will be discussing some of those incremental rate impacts first in executive session. And that is squarely a question that can be revisited by the board for the 2024 plan year. I know that there are members of the public that have been highly engaged on this, and just want to keep reminding people that we're going through a multi-month process, and we're at that stage, and we'll be sharing some of the initial incremental proprietary negotiation pieces even this later today with you in executive session, and then eventually some of that information as well as your final decision in the next 2 months as we round out the board season.
Any questions for Christine?
I just had one question. If we went back to the KP statement, did they make any fundamental changes to the way it was structured based on community feedback? I see in here to provide more choice in pharmacy benefit offerings, or is that more of as we look forward to how this would look, it might look differently?
So there's really 2 kind of answers to that, Allison. The first piece is Kaiser was really promoting and encouraging employers through their renewals to pick up the First Fill program. and they've changed some of their language to be much more ensuring discretionary choice among employers, and aren't as more proactively, strongly encouraging and kind of assuming uptake of it. So the fact that there is this revisiting by the board here, as well as is happening with other employers, there's much more accommodation and willingness to accept different types of choices, employer by employer or plan by plan. So that's one aspect of it. The other piece is, as implementation of this was having challenges at the beginning of the year, there were some more accommodations that were made. The hallmark of the first fill program was you get your first fill, but really you can get your second fill to learn more about this process. And in a lot of instances, there was a third fill that was allowed, or depending on the medication, maybe a little bit more grace there. So there were some, while knowing that a lot of employers would likely revisit this for the 2024 plan year, there was a little bit more flexibility than maybe had originally been envisioned for the immediate plan year. So those are two ways that kind of fit that part of the sentence whenever I look at it.
That's really helpful. I think, there's a couple of things that come to my mind is just, it is hard to understand your benefit. And when it shifts to know this is the thing that this really means. And so that partnership, I suspect, between the employer and KP becomes even more critical in that cascading communication side of it. And I think we have to be honest that part of this allows us to continue to control some of the cost by creating some of that efficiency. And so, we don't like that. We also like to see those rates continuing to grow at such a aggressive amount that it, forces conversations both at an employer level and certainly in this instance, at a system level of, can we actually afford the richness of the benefits? And I think that's often missed in the consumer education side of things of, this is not an ATM machine where you just keep pulling things out. Like there's a balance to be created. And I don't think we're doing a very good job as the American public in understanding where healthcare costs come from and where we may have, that feels annoying until I get used to the new system. And then my medicine just comes in my mail. That seems good kind of thing. So.
Yeah, and Allison, I think the other challenge that we have with helping, and you're right, it's not just an HC, it's an American psyche healthcare challenge, is in general, we all know that for a variety of different reasons, there's a lot of upward pressure on rates. And so to say it could have been $5 worse just isn't a message that resonates with people. They're saying, oh, I thought if these costs this is a cost containment measure, for example, would place that puts downward pressure on the rates, but if it doesn't overcome trend, you still see a rate increase. And that is a kind of a cognitive dissonance challenge with really pushing that type of message out. Because it never feels good to say, oh, it could have been worse. Or it would have been worse. It's still, rate still went up, and it would have been up even more without this type of piece. This is something that we're just ingrained to really internalize and really, kind of accept. So that's another just challenge with all of this.
And Allison, ATM, it does come out of your account.
I'm just thinking it just feels like that was maybe not the right analogy there.
If you find that
I was
ATM,
like-
Allison, though, please let us know.
I know,
Yeah.
I was like,
I was thinking your bank account had just.
well, good luck with
coming out.
that.
Fair enough, it was card trick. Maybe that's how I feel with my kids.
Yes, you are the ATM. Any other questions? All right, Christine, thank you.
Thank you.
Next up, Shauna Lang, Portfolio Management and Monitoring Section Manager in the Employees and Retirees Benefits Division, is going to be providing us with some information regarding the federal public health emergency ending and its effect it will have on the SEBB program. Her presentation includes a proposed resolution on COVID-19 over-the-counter test coverage. No action scheduled for this resolution today. Her materials behind tab number 7. Shauna, welcome. We're bringing out the big guns today, huh?
Yes.
All right.
Great. Good afternoon, Chair McDermott and members of the board. My name is Shauna Lang. I'm the section manager for portfolio management and monitoring. I'll be giving an update on a public health emergency unwind and presenting a proposed resolution for coverage of over-the-counter COVID test kits for UMP. All right. The federal public emergency coverage ended on May 11th, 2023. The PHE coverage included cost shares, waivers for COVID-19 testing, including lab and respiratory, and over-the-counter test kits. PHE also included coverage for antibody tests when done in an inpatient setting, late on state, and outpatient for children with inflammatory syndrome. Next slide, please. Under the Families First Coronavirus Response Act, there were certain requirements that must be met for maintenance of eligibility prohibited in states of terminating or reducing benefits for most Medicaid enrollees for the COVID-19 PHE and kept coverage regardless of income changes. So during the PHE, Washington Apple Health enrollment increased to 450,000 between March 2020 and April 2023. Next slide, please. For HCA in the Apple Health unwind for the PHE, HCA is actively working on requirements of the Consolidated Appropriations Act to draw down enhanced funding from the federal government and to continue receiving through the unwind period. There are conditional requirements to draw down to the enhanced federal medical assistant percentage, such as these requirements are certain redetermination requirements in accordance with the Social Security Act. States may make good faith efforts to make up-to-date contact information for clients. Between April 1st, 2023 and June 30th, 2024, states must report certain data elements. Data will be made publicly available. States may face penalties and corrective action plans if they fail to meet these requirements. The defined unwind transition period is between April 1st, 2023 and December 31st, 2023. HCA also launched a comprehensive outreach campaign to help individual transition care during coverages redeterminations happening. These include weekly Gov deliveries, partnering with state agencies, social media campaigns, postcards, printed materials, training webinars, and others. Next slide, please. This slide shares more information on Apple Health resources and the impact to PHE. It includes information on HCA's response, FAQs, and impacts to Apple Health data and contact information.
Shauna, real quick, I want to highlight that on the prior slide, we don't need to go back to it, but every member on Apple Health, all 2.3 million members, and Allison's probably more keenly aware of this given her role with Medicaid, are having a redetermination, and there will be individuals who are ultimately dropped or their coverage is removed for Apple Health. And so some of those individuals will end up transferring to other employer-sponsored healthcare. Some of them may be brought on or moved into dependents, even in the PEB and SEB program. Some of them will go to the exchange and maybe be able to get subsidized coverage there, and some of them may end up uninsured. So there's a lot of this work will impact all aspects of our kind of our healthcare market, and that's why we wanted to share a little bit more with you about that type of work. It's a mammoth amount of work that this agency will be doing on a month-by-month basis for over the next year, but it does have implications because the projection is a couple 100,000 individuals after all the redeterminations are done will not be on Apple Health, and they will hopefully be covered somewhere in our system, some in PEB and SEB, like I said, but it's just an important kind of transition that's going to happen in our market.
Yeah, and I just wanted to reassure folks that, this is a big, huge deal. The agency is working closely with the Gov's office, OFM, with DSHS, with the exchange, making sure that communication goes out, that we contact people, that because people move, things change, and make sure we engage them, and then all of a sudden they don't find out they don't have insurance when they go to the doc. So there is a massive effort going on between all the entities to make sure that people know what their options are, but we are required to do the redetermination, and it is what it is, and I think you have unintended consequences. I don't think the federal government anticipated, a 2.5-3 year ordeal with COVID. And so when these rules got put in place, there were people that are now stacking up on Medicaid who may or may not be eligible at the time of redetermination. So Our hope is most of them find an insurance plan, either through the exchange, through their employer, as a dependent, but we'll see. And we can bring more information, back to the board as it unfolds.
I'm really appreciating it being brought to this group because I think, there's sort of a Medicaid network of folks who are, one, we've been anticipating this for a little bit of time and lots of work, but it's sort of around the edges that are the people we're most concerned with. And the more it gets normalized into conversation, I think is, going to be helpful. And it's likely to have us learn some ways of where we can find some better communication strategies overall that I think go back to when benefits change, like how are you actually capturing people's attention when they think, I did this, I'm good. I don't even know. I mean, I don't know that it's funny, but we often comment on folks who don't know the difference between Medicaid, Apple Health, and who their payer is. And so you just, the level of literacy is not particularly high, but I appreciate the presentation because I think the more all of us are thinking about who might not know they've got to go through this process, the better.
Back to you, Shauna.
All right, thank you. So now a highlight on the PEB program and the unwinding of PHE in each of our carriers. So Premera's coverage for COVID treatment lab tests will be paid at standard plan benefits, and over-the-counter test kits will no longer be covered. Vaccines will be covered under the preventative benefit. Next slide, please. Kaiser's coverage for COVID treatment lab tests will be paid at the standard plan benefits, and over-the-counter test kits will no longer be covered. Vaccines will also be covered under the preventative benefit. Next slide, please. UMP's coverage for COVID treatment lab tests will pay at standard benefits. Over-the-counter test kits are no longer covered as of May 11th. Vaccines will be covered under the preventative benefit. This also moves towards the changes that we're looking for July 1st for over-the-counter COVID test kits for UMP. Next slide, please. During PHE, COVID over-the-counter test kits were required to be covered up to 8 tests per month per member, with a maximum reimbursement of $12 per kit. The biennial operating budget passed by the legislature, provided coverage of 2 over-the-counter COVID test kits per member per month with a cost share up to $12 per kit, beginning on July 1st, 2023 for UMP plans. And that leads us to the proposed resolution. The proposed resolution reads as follows. Beginning July 1st, 2023, all uniform medical plans will cover up to 2 over-the-counter COVID-19 diagnostic tests per member per month, up to $12 per test without member cost share. If the IRS guidance and issues future guidance that requires deductible be met prior to plan payment for over-the-counter COVID-19 test kits in high deductible health plans, the UMP high deductible health plan shall be amended to comply with IRS guidelines without further action by this board. Are there any questions or comments?
So this is Dave. I did want to say, there's some signals that the IRS has had complicated guidance and always has complicated guidance related to the high deductible health plans and what is or isn't allowed to be pre-deductible. And sometimes the definition of preventive is not necessarily intuitive. And so we're just anticipating that there's the possibility that something could happen with IRS guidance in that area. And so this is kind of a theme that relates back to Janice's resolution of wanting to have the authority to align with and make sure that the plan is ultimately qualified for those HSA contributions. There's nothing that inherently is saying that the IRS will make a change on that point, but it's also enough tea leaves that people are expecting that there could be a change there. And so just to step back for a moment, if you do it, for the past couple of years, over-the-counter tests covered no cost share. as of a month ago, no coverage for over-the-counter tests. And now we're saying, come 3 weeks from now, there's now budget authority to have 2 per member per month in UMP. You'll notice though that from Shauna's past couple of slides that is going to be a richer benefit than most other parts of the insurance market and even our own portfolio. But it was seen as an important, potentially, mitigating impact for either future waves or, by the time there was something to respond to, there wouldn't be the ability to respond. So it was like, let's set a small level threshold, and it was included at the very end of the budget negotiation process as authority for inclusion. So we're just bringing it to you to kind of more formalize that policy. So it is funded and included within the future rates that you're going to see as we go over the next couple of weeks.
Any other questions for Shauna? Seeing none. Thank you, Shauna.
Thank you.
All right. Is there anyone on Zoom that would like to provide comments? We're in the public comment portion. Anyone on site that would like to provide comments? We're going to gather the list and so we can effectively manage the time. If you're virtual, please click your virtual hand if you'd like to speak. And is there anyone in the room that would like to speak? Seeing no one virtually, seeing no one in the room. Our next meeting is going to be June 22nd, 2023 from 9 to 1:30 with the same format of attendance in person or via Zoom. Dave, any final comments before we head into executive session?
Just that as we have 3 more meetings scheduled, or actually I think there's 4 on the books because we always leave buffer in case one's needed, but we have 3 more meetings that are anticipated this board season, a variety of topics over them, but the hallmark of them is bringing you the rates related to the 2024 renewals for the various plans. We anticipate that will be in the July meetings. The first meeting in July, which I believe is the 6th, is where we'll have the public presentation of those. We'll be talking with you in executive session today and on the 22nd. I hope I'm not saying the PEB dates. The 22nd, we'll be having additional executive session conversation about them. And then we'll be highlighting in the public meetings come July, both those proposals as well as the specific granular benefit changes that are embodied within the fully insured carriers proposed rates. So that's really kind of the key part of it. That will also include the conversation around the first fill program within the Kaiser benefits. And we do have a variety of other, we'll be talking about benefits 24/7, how that transition is going, and also about some of our preparatory work for open enrollment. So just a little bit of a preview of coming attractions for the next really 5 weeks, 5-6 weeks. And then we will be near the end of board season.
Did you say July 6th?
I did say July 6th.
You were correct.
Okay, good.
July 6th. Yep, nice job.
Don't ask me the one after that, though.
Good memory. That doesn't matter. We're 2 out, right?
Yep.
All right. Any other comments from the board before we head into exec? All right. Exec session is going to happen here in the Sue Crystal room for board members and include HCA employees. At this time, members of the public joining us in person at the Healthcare Authority today, as well as employees not part of the executive session, will be escorted by staff to the lobby for the duration of our executive session. You'll be called back to join us in Sue Crystal for the remainder of the public meeting, which is going to be a brief closure after the executive session has concluded. Pursuant to RCW, okay. Oh, I see it. L. That's nice. Pursuant to RCW 42.30.1101L, the board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state purchased healthcare services as provided in RCW 4105.026. The exec session will conclude no later than 12:30 p.m. Let's go ahead and take a 5-minute break while we transition the room for exec session and return to our public meeting to adjourn after exec session. All right, let's do it.
Red means on.
All right, folks, we're back from exec session, and I'd like to thank everybody for today's work, and this meeting is adjourned.